Got it. Yeah, but most of my time I spend at the National Healthcare Institute, which is a independent government body. We advise the government, we advise politics, the Ministry of Health with regard to the content and of the basic healthcare package. We also have statutory and legal tasks with regard to quality and transparency in healthcare. We have not a budgetary task, but we develop information standards and all based on the rules and regulations of the Netherlands. On request of Kaylin, I show you this little film, which I hope works. Yeah, I think it will work. It's very short.
Every person in the Netherlands is entitled to healthcare offered in the basic care package. We all contribute to this through our health insurance. The National Healthcare Institute determines and advises on which types of healthcare are included in the basic package and which are not. Treatment possibilities and their related costs have increased in recent years and will continue to increase. These treatments are also often used for a broad group of patients. The Care Institute therefore wants to draw more attention to how insured care can be offered. Who receives which care? Professionals largely determine what type of care to offer for which health issue. But is this care necessary and effective for every patient? Is appropriate care being applied? To determine this, we need to focus on what takes place in the consultation room, where the doctor and patient together decide on the best treatment. This requires good collaboration with professionals and patients on the application of appropriate care. We encourage healthcare partners to structure their guidelines and quality standards to provide the individual patient with a proper care. We do this together with scientific organizations, as well as healthcare providers, patient organizations, and health insurers. In other words, we continuously monitor the scope of the basic package. We also call for greater focus on collaboration to ensure appropriate care. This enables us to reduce pressure on the boundaries of the package and keep the insured care accessible, of good quality and affordable, now and in the future. Taking care of good healthcare, no more and no less than necessary.
Okay, I didn't know if there was any parallel institute in Australia. Is there? Is there, of course, you have universal healthcare coverage, but is that some kind of institute which, on behalf of the government, sees to it? Yeah? Which is?
There's several.
Yeah.
May I offer a response? So there's the National Ministry of Health, which is responsible for the policy, just like we have in the Netherlands. Then there is the Australian Commission on Safety and Quality in Healthcare.
Yeah, evidently. Yeah.
Which looks at, especially what it says, quality and safety. There's another body called the Independent Hospital Pricing Authority.
Ah, yeah.
Which
Yeah.
So your group, your body does multiple of these. We just have different bodies doing different.
Yeah.
And then a lot of the care is delivered and funded by the states. So we have 6 states and 2 territories, and they deliver a lot of the care.
Yeah.
So they have a lot of responsibilities for this group at the moment.
Yeah, they hold the stakes in their respect. Yeah.
Can I ask a question in return?
Sure.
Is this NIVEL?
No, this is very good of you. Now, this is no, okay. NIVEL is actually a small research group with regard to what we call the first line in healthcare, which are GPs, basically. GPs, they have the GPs are the doormen and women. They decide if somebody will go into the healthcare system or will do some self-management or whatever. And NIVEL is the institute that holds some registrations and has some professors, and they work with universities, but they are not state-owned. It's a kind of NGO-like, I would say, actually. Yeah. Okay, transitions.
Sorry, just quickly, Hans, I just want to check you're in presenter view because it's coming up a little funny for me that it says like what your next slide will be and that sort of thing. I'm not sure if that's appearing for everyone else.
Better?
Yes, that's perfect. Thank you.
Oh yeah, cool. Yeah. Yeah, this statement, do you think is a true statement? I was in Brisbane sitting on a terrace and I saw this girl, or actually I saw her bag and her dog, and written on the bag was "Everything happens for a reason." It's basically also a scientific statement. And I would like to have her as my student, evidently. But today I will share with you some, personal and political scientific stories with regard to transitions. Transitions are always our journeys. Journeys are always transitions. And this is not so much about my journey to your beautiful country. I was in Godumba yesterday, walking there for over 4 hours and had a great time. But this is more the journey with regard to what may be the greatest challenge for our healthcare system of our times, maybe the greatest challenge of humanity and civilization. Certainly, this has a physical origin. Have a look.
The cumulative scientific evidence is unequivocal. Climate change is a threat to human well-being and planetary health. Any further delay in concerted anticipatory global action on adaptation and mitigation will miss a brief and rapidly closing window of opportunity to secure a livable and sustainable future for all.
Need to act immediately. It is now or never. During this week, scientists in over 25 countries are engaging in protest, civil disobedience, strike, demand emergency action against the climate and ecological crisis.
It's not without immediate and deep emission reductions across all sectors, it will be impossible.
I used to say, when I was talking about climate change, that climate change is serious, certain, and soon. But this is no longer accurate. Now it is very serious, very certain, and now.
There's really one key message that emerges from this report. We are out of time.
The jury has reached the verdict, and it is damning. This report of the Intergovernmental Panel on Climate Change is a litany of broken climate promises. It is a file of shame, cataloging the empty pledges that put us firmly on track towards an unlivable. We are on a fast track to climate disaster. It is what science tells us will result from our current energy policies. Some government and business leaders are saying one thing, but doing another. Simply put, they are lying. Climate activists are sometimes depicted as dangerous radicals. But the truly dangerous radicals are the countries that are increasing the production of fossil fuels. Investing in new fossil fuel infrastructure is moral and economic merits. Demand that renewable energy is introduced now at speed and at scale. Demand an end to coal-fired power. Demand an end to all fossil fuel subsidies.
Yeah, this was half a year ago in The Hague. I engaged with with this group of scientists, 3 billion, out of solidarity with the young people on the street. I'm always with this other doctor. He's a pediatrician, actually, is one of the oldest people there, and it made me feel a little ashamed of that. And also, of course, because the public outcry on the street we have witnessed since a few years. And yeah, let's be honest, they have the right to be worried, the citizens and our patients and our children and other professional groups or workers or students or pupils who came out to the street to protest. In my institute, I've been working on this issue since about 2016, I think, and it amazed me more and more that many of my colleagues were not at all upset about these kinds of articles from the Lancet Countdown organization, independent organization of, I think, 23 academic research institutes all around the world, transdisciplinary. And the titles became more and more ominous every day. The health impacts are very clear. The evidence is mounting over the last years. The outcomes are there. This is a very recent outcome published in Nature. Over 60% of infectious diseases are actually aggravated by consequences of global warming. And you see, I expect that you all know these kind of causal pathways between global warming and health outcomes. And it is not actually just, of course, the global warming. This is actually the bigger picture. Many lectures are start with the sentence, our health depends on the health of the planet. And everybody understands that immediately. It's an open door. It's, of course, also an old shamanistic wisdom, actually, which is sustained by more and more evidence. On the left-hand side, you see the big underlying drivers of consumption and production trends, technology trends, and, of course, growing population leading towards a signature on the earth in the Anthropocene, this new age of man, and this signature is not to be wiped out anymore. We leave our traces on the planet, and you can see that in pollution, in warning, in global warming, and other so-called planetary boundaries have been reached. We have the Stockholm Resilience Center, maybe you know it, Siri. The Earth is very much able to absorb all kinds of impacts, but there are boundaries to that. Well, depending on the filters of your country, when you live in high resource countries, there are more filters that for the harder effects of these planetary changes with regard to health. So what the board member said to me, yeah, Hans, it's actually a great idea for our calendar, but we are so busy already, you know, don't make it too big. Maybe for our next multi-annual agenda, this is something. And this elicited a kind of rebellious feeling inside of myself. And yeah, we have COVID, we have capacity problems. Meanwhile, this is also happening, of course, it's a kind of bi-directional relationship. You all know that the healthcare industry, with their business operations, so to say, produces, in a way, climate change, and climate change produces health impacts, etc. Okay, we know this on a planetary scale. The impact is quite substantial. In the Netherlands, it's about 7.3 only in greenhouse gas emission. This is very recent. My friends and colleagues from the National Public Health Institute have published this. And this is a full footprint. It is actually composed of 5 components. Mostly we speak about carbon dioxide emission because that's something which is measurable and doable, hard enough. But these are other forms. I can give more information on this at another time, but many countries are working now to, maybe also Australia, to calculate or estimate their footprint. Meanwhile, we had a national policy done by the Ministry of Health. This is actually a kind of collaborative policy document in which over 300 healthcare related parties undersigned a document and promised to accelerate sustainability in all their operations. There were no benefits or there was no punishment if you wouldn't do it. And these, sustainability can be anything in our language, of course. It can be the financial, economic tenability of the system, but here, of course, we mean the reduction of the ecological footprint, which was operationalized into 4 basic elements: carbon dioxide reduction, of course, and also making healthcare more circular, less waste production, less medicine waste, and promoting prevention, healthy lifestyle, etc. Okay, that for me, it was a moment at this National Healthcare Institute, which had no formal policy on sustainability, to say, well, okay, we have undersigned this document, now we have to act. In this document, we basically said that others had to do it. But I wanted actually to try to institutionalize sustainability in our mission, in our task. I mean, also in our own building, which was not so much of my interest. I mean, that's okay. We should do that. We walk the talk. At the end of the day, catering and food and traveling, etc., should be sustainable as well. But in our mission, and our mission is with regard to the healthcare quality in the Netherlands, and of course with regard to the package, the universal health coverage. So yeah. This transition from within, it was very interesting. I mean, I teach about transition at university, but now I was an actor in the transition from within myself. And we use all methods. I mean, not just out of the theory book. I call it management by bluff. I don't know if it exists in theory, but well, we just we stated that our institute was going green and working on it. And even if in the letter, every year the ministry writes a letter, a kind of framework letter, this is what our institute is supposed to do. And we managed to get sustainability into this kind of assignment letter. We started all kind of green research, small projects, but with an impact. We used the language of the institute, the tools of the institute. We played, we were rocking the boat, but staying in it. That was the idea. And of course, we engaged with our partners in our context. We organized a Green Week for awareness, etc., all kinds of things. Yeah, 2018. That was in 2019. Because of that, and because of management by bluff, I was sort of invited by ISQA in Cape Town, and the board I seduced to accept a climate statement, which they did, and we have seen the fruits of that last conference in Brisbane, where many themes and sessions were related to climate change and health. And yeah, at the same time, back home, these other things in our environment took place, which facilitated the sustainability integration mission. We have a quality framework in which guidelines and standards and measurement methods are shown that are proved, have evidence for producing quality in healthcare. We managed to have sustainability of one of the indicators in this national framework, which is supported by healthcare providers and by insurance, etc. With our first publications coming, we had a national appropriate care campaign together with another pillar of our system. We had an influential television and internet information campaign based on scientific reports that the system was just not tenable in the future anymore in a financial economical sense. We had a kind of ominous video of a GP whose waiting room became too crowded. Many people were there. They could not be helped. We have an incredible capacity problem, like in your country, like in many countries. I mean, at the Ministry of Health, I hear nothing else. I only hear about this issue. And yeah, I mean, it's not, you know, we can solve it with more money, for instance. There's just not enough people. So we have a campaign for appropriate care, which also means, of course, patient-centered care. It means reduction of inappropriate care, unnecessary care, etc. But it also means green care. That was what I was proposing in the beginning, and it has been accepted. Appropriate care is care with the smallest footprint possible. We don't know what that is, actually. And of course, we know some generic things in the width of healthcare, but of course we need to have more information about the more vertical issues with regard to cardiovascular disciplines or respiratory disease, whatever. Okay, last year we committed to decarbonize healthcare system in the wake of the COP26 conference in Glasgow. And in our environment, more stakeholders were going green, so to say. I mean, there's a lot of greenwashing. Who can be against sustainability or against being green? Well, not Shell, for instance, or British Petroleum. Of course, everybody loves ecology. Okay, this year, only a few months ago, we succeeded in having actually formalized this green team, meaning we have resources, we deliver reports, we are integrated in formal policy documents, and we have a kind of action plan for the coming year. This is a little list of the small research project we have been doing. One influential one is about replacing the propellant inhalers in respiratory care with the powder inhalers. We did it as a data analysis, and it actually showed that this is something which is easy to be done, and it has quite an impact. I mean, it's a drop, you know, it's maybe worth the emission of 7,000 households in the Netherlands, but it also saved 50 million euros. It's not much on 100 billion euros, but we show actually that to healthcare professionals, it's possible. It's not rocket science. You can do it with the same safety and quality as you're used to be. Okay, we worked on green health technology assessment. I can tell you there's not much going on in the world at the moment. NICE is doing something. The Canadians in Sweden and we in the Netherlands are trying to include environmental factors into the assessment of new technologies. And technology mostly is to be understood as medicines. But also increasingly, for instance, e-health or telemedicine. That's one thing we do at our institute. So, and in the new definition of HTA, which was published 2 years ago, explicitly environmental factors were implied. So we did some philosophical work also on solidarity and sustainability. We did very practical work on calculating the carbon dioxide in oncological pathways. Spillage. You will all recognize these themes. They all have to do with reducing the ecological footprint. Okay, we have some policy actions, not just research, but we encourage all our stakeholders to do the same, to include reducing these ecological footprint. I mean, like in Australia, it's not the old government model of carrot and the stick. I mean, we are in the same playing field. We play together. We have different roles. So that's how we work. We need more green metrics, so to say, and we need to form, I call them transformational coalitions with parties you do not usually think of, not the usual suspects, but other parties. Okay, A short break. Oh, baby fail. Yeah, this is actually an example of these transformational coalitions that I mentioned. I mean, working with artists or musicians or other disciplines can be very powerful to fuel the imagination. Oh. This was made by Maria Kojic, the German artist. Yeah, this is actually our assignment. How do we cure people? How do we prevent people from getting ill without damaging our environment, without damaging our environment at large? Global health, planetary health. And we need a system to deliver healthcare quality. We need a financial system, and we need the operational infrastructure to do that, based on what we already have. And this is a colossal task, of course, because we have a very intricate, complex system to deal with. But we have tools. For instance, recently translated in French and Dutch, even this influential report with about 7 impacts delivered by Healthcare Without Harm, an NGO which has been on the block for about 10 years. Healthcare Without Harm means, of course, the Hippocrates Oath that many doctors swear in the Netherlands, maybe also in Australia. It's you don't have to do it. You do it out of free will. And in this oath, of course, it's whatever you do, do no harm. Healthcare Without Harm implies that. And here is actually the looking glass on the business operation of the healthcare industry, of the healthcare system. Yeah, the WHO has, of course, all of you know this building block picture, and you could look with the eye of sustainability to all of these blocks, and to actually, it's not so hard to do. We have tools for that. Also with the glass, the looking glass of resilience, for instance. Resilience meaning the capacity of a system to for instance, if you see here on the right, there are about 5 possible outcomes after collapse or impact, which is the breakdown and the recovery worse than before. But it's also possible to recover, or to resist, or even to transform the system. It is helpful. Resilience leading to less vulnerability of both people and processes and systems. And maybe a better capacity and improved health outcomes. There are more tools. I mean, this is what I teach my students. I frame an eco-friendly system as a form of innovation, and it's plausible. It is a way of innovating. It is a way of improving healthcare, because a better environment improves healthcare for population and individuals. yeah, in the Netherlands, we have these tools. You're probably in Australia also working on this. How are you actually going to do it practically with all the other stresses on the system? Capacity issue, financial issues, zoonosis, focus and attention, measure what you do, and communicate. I mean, there are all kinds of roadmaps. We have quite a few examples in the Netherlands coming out of the bosom of the healthcare industry. Only recently, I must say, climate and environment have not been very high on the agenda of healthcare. On the other hand, healthcare has not been very high on the agenda of the United Nations, for instance. But this is about climate responsible entrepreneurship. If you are a GP, or you have a practice with 2 or 3 more people, you have a building, you have bricks, you have bytes, you have waste generation, etc. This is actually a way of how to deal with that, being an entrepreneur. This is interesting for all of you interested, of course, in quality improvement. This is one attempt of Francis Mortimer, nephrologist from the UK. You know, I mean, we have had these discussions on what actually is value in healthcare. Well, how do we grasp that and improve value? And she said, yeah, under the bottom line, we need a third component, which is actually the environment with the social impact. And at the end, to increase the benefit for patients and populations. Okay, appropriate care, you all know what that is. I mean, Jeffrey has been speaking about that in Brisbane and publishing about that. Yeah, it's incredible. It's about the same in our country. Maybe 20% is deemed to be unnecessary care. And you don't hear much about it, but it's also unethical, of course. I mean, people say, well, if it doesn't harm, who cares, you know? But it's totally unethical in a way. But it's hard. I mean, we all know studies that look into motivations, and it's not bad will, so to say. It happens. It has to do with consumerism, has to do with our processes. But if we can cut out these 20%, we have won a lot. Also in terms of reducing the ecological footprint. This is typical Dutch, the chemofiets. Fiets is a bike. Medicines are brought to the domestic environment of the patient. Patients like it. And there's no, it's carbon dioxide free, of course. There's less stress involved for patients. This is a pilot experiment of an Amsterdam hospital. Of course, an interesting subject. We are currently investigating the contribution for e-health or telemedicine by wearables to reducing the ecological footprint. We do that based on data. There's much to do about it, but I never have seen quantitative studies with regard to this. Only the promising potential of e-health for everything, but also for sustainable healthcare. Other, many examples can be done. What is interesting is that young professionals started with this, young surgeons. They were influenced by, the ways they see or the simple actions they can take. For instance, in the Netherlands, it was almost 1% of the total footprint of healthcare was caused by the narcotic gases. It's actually very, very simple. You just do it intravenously. It's almost always possible, according to surgeons who want to do that. But of course, you have to deal with attitude, with motivation. I learned it this way. My professor learned it this way. The culture of my department is not like that. And there are many, for children, it's not, as good, or for them, etc. Okay, another, interesting study done by a government institute with regard to prevention and lifestyle, food, animals, healing environments, green environments. I visited a hospital where the recovery department had a view on the woods, actually on the edge of a wood. And yeah, believe it or not, I think it was half a day less being, after surgery in the recovery department, which basically, if you accumulate that on a yearly basis, it's a lot of money. And so, well, there's some evidence for all of that, but still, it's still in the beginning in the Netherlands. Many people think the Netherlands is at the forefront of, for instance, e-health or greenifying healthcare, but it's actually not true. These are all small examples, but it's growing. There's more growing momentum, but still, the national policies are unclear. There are no objectives, and especially now, it's not clear how much public money is invested in it. What do the system parties do? The inspectorate, the healthcare authority. We are trying to take our role, but insurers have a crucial role in the Netherlands. I mean, they decide what is quality, what do they buy. We need more metrics actually to have our decisions based on that. And at the end of the day, I think that's my professional, personal opinion. We need kind of a task force to underscore the urgency of climate change. I actually, it may be my own tunnel vision, but I cannot really see anything bigger than this. And the authors of the IPCC report, they were asked a few months ago. It was published in Nature, and this is actually bad news. You authors, do you think this objective is feasible? And here you say, well, this objective of 1.5 degrees Celsius, yeah, very little people think it is feasible, and we are going to 3 degrees at least, we think. Yeah, recently last week, this report is it's not nice reading, dear people, but I mean it's bad news, but we have an action perspective, and we have to stay true to science and cut emissions down. That's the beginning. I was telling about this scientist rebellion thing. This is actually a funny cartoon, because yeah, we can worry about COVID-19, but it's actually a small thing with what is going to happen. And here I am at the end of it. Next. Thank you for listening. I will be here for a few more days, so I mean, maybe I was a bit late with this.
No, I was going to say one of the really great things is that just because we're not all in the same place doesn't mean we can't collaborate. I mean, we have a lot of people online listening to this, and
that's true.
I was just thinking there's a health economist working on degrowth in Melbourne that I need to connect you with, Martin Tenscher. He came to our December climate change and health system sustainability event. Yeah. So, this is only the beginning of the conversation, because there's so much more work to do. Yeah. Were there any questions either online or here that anyone wanted to ask Han? Well, we do have him.
Thanks, Han. I'm interested in the diagnostics. So in my experience in a hospital, there's like an overuse of diagnostic imaging. And it often comes from the issue in that clinicians have lost that skill to make decisions without relying on MRIs, for example, that have huge carbon emission. How do you see going forward with that? I mean, it seems to me that they've sort of gone backwards. They want more tests, and often the tests aren't relevant to the patient. And I know radiologists will push back then, so they're learning to push back. But it concerns me that a lot of doctors have lost these basic skills to diagnose clinically without relying on all these tests.
Yeah, I don't know if they've lost their skills, but it's all too human. They don't want to miss out. They don't want to miss out on a diagnosis. And I mean, there are actually very funny stories if you go along with it. If a GP refers to the second line, I mean, there's a joke among medical doctors that a healthy person is a person who has not been investigated sufficiently, and it's true. I mean, I feel totally healthy now, but if I would, I mean, there would be a little shadow on my liver. Oh, might be cancer. We dive into it. Well, it's not cancer, but it's maybe something. And there's another, and at the end of the day,
I guess I'm talking more about the inpatient setting, where you have other alternatives in the hospital that don't necessarily equate to expensive imaging tests, where doctors could make have decisions without them.
Yeah.
Mm.
Yeah, it is definitely to do not only with the individual decisions of doctors, but also with the, you know, with the culture at the department. And
Yeah.
I mean, many doctors feel like their patients always want more, but that is not always the case. I mean, with regard to these inhalers we were investigating, we are now doing an implementation research. How do we get it on the ground? How do we get doctors to prescribe in another way than they were used to do? How do we get patients to accept that this is as good as? So, and patients want that. I hear that from interviews already in focus groups. And I mean, in the top 3 of what worries people most in the Netherlands, it is yearly surveyed. Climate and worries about the healthcare system, the tenability of the healthcare system are in the top 3. So this is the connection. Come on. And of course, we need professionals to do that in the restricted time they have. So yeah. But in healthcare, climate activists, there is a very good energy. There's no complaining about capacity, about money. There's a strong energy of, hey, this is so big, we have to act on this. So yeah.
Can I pick up on that? That's a fantastic talk. Thank you very much. We're privileged to have. There's 2 bits that I heard. One was up and one was down. One bit is you've specified a whole lot of stuff that's subject to implementation science.
Yeah.
And if we're really good at that, working in collaboration with the system, with researchers, with policymakers, a lot of what you said is implementable with good will and clever techniques. And we research a lot of that, and we're here to help that, the people who deliver. So that it's an implementation science problem. But there's a bigger issue, isn't there? The big issue is, why are we in such a state? It's obvious what you see is totally logical, compelling, persuasive.
Yeah.
And what the hell are we doing, not doing with that?
Yeah, it's true.
And it's clearly, we come from 2 countries that have a big stake in this. The Netherlands is low lying, and you know, although lots of engineers, world experts in water, you are severely at risk. And Australia isn't low lying. The height of Australia is not its problem.
Yeah.
It's the driest continent, and it's subject to drought and wildfires and all sorts of. You think we need to have scientists. You know,
I'm sure you.
The case is so the case you put is so compelling. So how come?
Yeah.
We're not making the progress we should.
Have you seen this movie Don't Look Up?
Yeah.
Yeah, I mean, what can I say? This is how it works, I think. I mean, for instance, with this Jacques Weimar, he's a gynecologist, he's a chairman of our board. I'm on very good terms with him. I mean, I've been speaking with him about this about 6 years, maybe. But now, this is a very prosaic or trivial fact, what I see now doing. He's coming to the end of his pension. He can end up as a doctor bureaucrat, or he can end up as somebody who has changed the system and bring it to the next level. What is more interesting? He has become grandfather. You know, he has to, he talks with his children about climate change. He's totally convinced. And he says to me, yeah, you've been a caller in the desert or something. What is this biblical expression? Calling in the desert, things like that. Yeah, sometimes people have to hear from 5 different sides, from their loved ones, from their maybe from their child, or from an expert. There are meters of books about climate psychology, Jeff. You know, I mean, it's incredible, and it's so hard to change because we are at the height of our consumption and production levels. I mean. We work, even if it's hot outside, we work in a pleasant climate. We have technology, we have food, it's incredible. And it's not like, it has a price. And we cannot go on with that. And I mean, we talk about sustainability a lot, but what is maybe more interesting in this sense is the term regeneration, which is more than not doing damage. It is about adding to ecology. A very simple example was in the Netherlands. They made these phase maps of a degradable plant-like thing, and if you threw them away, there were flower seeds in them. So that's just preventing waste. It's a very simple example. Yeah. But this is about improvement science, isn't it? From our perspective. So that's what we can contribute from science, I think, and that's what we must. It's my opinion. Don't worry.
So while you go underwater and we burn, Norway is going to be growing groves.
Yes. And that's why everybody's fleeing to Norway now. So yeah. Yes.
I've had the pleasure to collaborate with Dutch colleagues since 2010. And one of the works that we did in 2014 and a couple of years ago was to look into the understanding of quality and how it's conceptualized in 5 countries, among yours and ours. And I was wondering if you have incorporated a climate impact in the official Dutch definition of quality. Is that what you said? And secondly, is this now integrated into the regulation and being inspected by the Health and Care and Youth Inspectorate? If that would be interesting, because they are responsible for the quality and safety.
Yeah. Well.
So I was just wondering if that's happened.
Yeah. To specifically answer, I need some names and institutes where you worked with, but from my perspective, from the National Healthcare Institute, the state does not define quality. We say, as a representative of the institute, we say, well, quality is defined by the surgeon, by the lung doctors, but since you work with public money, you have to write down transparently the state of the art according to science and what the care is, doing daily. You have to write it down in care standards, make it measurable. And these care standards, guidelines, measuring methods, they are placed in a quality framework, which can be viewed by everybody, by the public. And what we did is also, integrate sustainability into that. But this is, it's all paper. We have to do it on the ground. It's very practical also. But there's no standard definition of what is quality. We say at the moment we have this campaign of appropriate care. And this is when we say, I say it all the time, appropriate care is green care. And the other way around.
Thank you. We've run out of time. What an amazing talk. Thank you very much. And
thank you very much.
We have recorded it, and with your permission, we will actually.
Sure.
It will be available to the attendees today.
Absolutely.
All right. Thank you everyone for coming, and thank you again.
I will